Unlucky on the tennis court. According to the clinical textbook we are tearing into today, three-quarters of all tendon injuries are the direct result of highly specific and completely avoidable training errors.
Yeah, and today we are looking at a text that essentially proves most of the injuries we try to treat with, ice and rest and ibuprofen aren't actually healing at all.
Which is going to blow a lot of minds, I think. So for everyone listening, the source material today is a dense, highly specialized clinical excerpt. It focuses on client-centered exercise prescription.
Exactly. I mean, it is essentially the operating manual for human soft tissue. It moves way past the basic advice of just like stretch before you run.
Right, we are going depth today.
We really are. It dives into the microscopic cellular realities of kinesiology and biomechanics. And the core premise here is that the human body is this incredibly sophisticated, highly adaptable architectural structure.
But it is a structure that obeys very strict laws of physics and biology.
Yes, perfectly said. And when you violate those laws, the architecture fails.
So the mission for this deep dive is to translate that dense clinical kinesiology into actionable knowledge for you. We are going to decode the actual science of injury and recovery.
Because by the end of this, you will understand your own body's blueprint. You will know how to spot the invisible warning signs of overuse, too.
And you'll understand why everything you thought you knew about treating a chronic injury might actually be making it worse. Okay, let's unpack this, starting with the absolute foundation of how the textbook defines an injury.
Yeah, this is a great place to start because the authors don't view an injury as an event. They view it as an equation.
An equation, I love that framing.
Right. The formula they present is really foundational to modern sports medicine. It is intrinsic risk plus extrinsic risk leads to injury.
So if we want to understand how tissue breaks, we have to isolate those two variables.
Exactly. And the intrinsic factors are the biomechanical and physiological characteristics that are totally unique to you.
So these are like the pre-existing conditions, right? The structural realities you carry with you before you ever pick up a dumbbell or lace up a running shoe.
Yeah, think of intrinsic risk like the structural integrity of a car.
Hmm.
We are talking about things like malalignment.
Okay, like what is a real-world example of that?
Well, for example, if you have what is clinically called valgus knee collapse, that is where your knees naturally bow slightly inward. Or if you have severely flat feet.
Oh, right. So those anatomical realities physically change how force travels up your leg when you move.
Exactly. The text also focuses heavily on muscle imbalances, which is probably the most common intrinsic risk factor in our modern sedentary world.
Because we all just sit at desks all day.
Right. Consider the posture of someone sitting at a computer all day. The pectoral muscles in the chest become chronically shortened and tight.
While the muscles in the upper back, like the rhomboids, get overstretched and weak.
Exactly. And that is a severe intrinsic risk. The shoulder joint is now permanently pulled forward out of its optimal position.
The text also points to things like inflexibility and hypermobility, which is fascinating.
Oh yeah, the hypermobility thing is super interesting because being quote-unquote double-jointed or overly flexible is often seen as like a party trick or a bonus.
Yeah, people think it is a superpower.
Right, but clinically it is a massive liability.
Right.
And then of course excess body weight is another factor. Every single one of these factors prevents the optimal symmetrical distribution of loading when you move.
So the critical takeaway regarding intrinsic risk is that it basically dictates your vulnerability threshold.
Yes, exactly. A slight pelvic tilt might not cause any noticeable pain when you are just walking around your house. The load is low enough that your body just compensates.
But that intrinsic flaw dramatically lowers your threshold for what external forces your tissues can actually tolerate before they begin to degrade.
Right, which brings us to the other side of the equation, the extrinsic factors.
The outside forces, so the equipment you use, the environment you are in, and most importantly, your technique and your training volume.
Yeah, and the textbook cites this 2005 study by Sadoff and Apfel that completely reframes how we should view these outside forces.
This is where that crazy 75% statistic originates, right?
Yes. They conducted an extensive review of tendon injuries and concluded that training errors are the primary extrinsic factor in three-quarters of all cases.
Wow. So we are talking about highly specific behavioral mistakes, doing too much too soon, too often, or with just too little rest.
Exactly. It is the classic weekend warrior syndrome. Someone sits at a desk Monday through Friday, cultivating those muscle imbalances we just talked about.
And then on Saturday, they decide to play like 3 hours of high-intensity pickleball.
Right. Or it's the amateur runner who decides to train for a half marathon and spikes their weekly mileage by 50% in a single week.
So the collision of those two variables is what actually creates the clinical failure.
Yeah, the intrinsic risk creates a localized point of structural weakness, and the extrinsic training error applies an overwhelming repetitive force directly to that weak point.
Going back to your car analogy, it is a perfect visual for this equation. Your intrinsic risk is driving a car with a rusted suspension and misaligned tires.
Right. And if you drive that car at 20 miles an hour on a perfectly paved, newly asphalted road, you might never have a breakdown.
Because the low extrinsic stress doesn't expose the intrinsic flaw.
Exactly. But the moment you take that exact same misaligned car and drive it at 80 miles an hour down a road,
Yeah.
completely cratered with deep potholes, catastrophic failure is totally inevitable.
The excessive speed and the potholes are your training errors. They are the extrinsic forces. Eventually, the axle just snaps.
Because the environment exposed the underlying flaw.
Hmm.
But, to really grasp what that snap looks like in a human being, the text forces us to zoom in past the muscles and the bones.
Right down to the microscopic architecture of our soft tissue. And the focus is primarily on three distinct structures here: ligaments, tendons, and cartilage.
Yeah, these three tissues form the connective scaffolding of the human body. And while they share some common biological materials, primarily collagen, their structural arrangements and distinct functions dictate entirely different mechanisms of injury.
So let's begin with ligaments. People often use the words ligament and tendon completely interchangeably, which the textbook points out is a massive clinical error.
Oh yeah, it is a huge mistake. Ligaments connect bone to bone. They are the passive stabilizers of our joints.
So their primary function is just to restrict abnormal movement and hold the skeletal structure together.
Exactly. The text details their composition as dense bands of collagenous fibers. But unlike a simple rope, these fibers are arranged in highly specific patterns.
Like parallel or oblique or spiral patterns.
Right, depending on the multidirectional forces that specific joint experiences.
The anterior cruciate ligament, the ACL in the knee, is a prime example of that spiral arrangement. It twists around itself to provide stability not just when the knee moves forward and back, but when it actually rotates.
Yeah, but the detail in the text that fundamentally changed how I view ligaments is their neurological function. They aren't just mechanical tape holding bones together.
They're sensory organs.
Yes. The textbook places heavy emphasis on the presence of proprioceptors within the ligamentous tissue.
And proprioceptors are specialized mechanoreceptors, basically microscopic neurological sensors embedded deep within those collagen fibers.
Exactly. They include structures like Ruffini endings and Pacinian corpuscles.
And their job is constant surveillance, right?
Yes. They continuously stream data to the central nervous system regarding the exact position of the joint in three-dimensional space. They track the velocity of its movement and the sheer amount of tension being applied to the tissue.
So this is the biological basis for kinesthetic awareness. Like if you close your eyes right now and touch your index finger to the tip of your nose, you don't need to see your arm to know where it is.
Right. That flawless coordination is proprioception at work. Your brain is reading the tension signals from the ligaments in your shoulder and elbow and wrist to map your body in real time.
The clinical implication here is just profound. When a patient suffers a ligament sprain, say they roll their ankle violently and stretch the lateral ligaments past their normal limit, they are not merely tearing physical collagen.
Exactly. They're physically severing those neurological sensors. The communication pathway to the brain is disrupted.
So the structural tape might be frayed, but the security alarm system is completely offline.
Right, which perfectly explains the phenomenon where someone who sprains their ankle once becomes incredibly prone to doing it again and again over the next few years.
Because the joint is left neurologically blind, the brain can no longer detect when the ankle is rolling into a dangerous position until it is entirely too late.
Exactly. The textbook insists that any rehabilitation program that only focuses on reducing swelling and strengthening the surrounding muscles is inadequate.
You have to implement specific proprioceptive retraining to reboot those sensors before clearing a client for functional activity.
We will dive into exactly what that retraining looks like later in the text, but for now we should move from bone-to-bone connections to muscle-to-bone connections, tendons.
Right, so if ligaments are the stabilizing tape, tendons are the dynamic cables of the body.
Yeah, a tendon's singular biological purpose is to transmit the massive, forceful mechanical pull of a contracting muscle directly into the bone to create skeletal movement.
And to withstand those sheer forces without tearing the internal organization of a tendon is just a marvel of biological hierarchy. Like it describes this nesting doll structure that is incredibly organized.
Yes, at the absolute microscopic level, you have tropocollagen molecules. These molecules bundle together to form subfibrils. The subfibrils bundle together to form fibrils.
And then the fibrils are bundled into larger structures called fascicles.
Exactly. The visual equivalent is the cross-section of a suspension bridge cable. Thousands of microscopic steel threads twisted into small wires, which are twisted into larger cords, which are finally bound into the massive main cable.
And the entire tendon structure is encased in an outer sheath called the epitendinium, which the text notes acts as a smooth, specialized sleeve.
Right. It produces a synovial-like fluid that allows this highly tensioned cable to glide friction-free across bones and other tissues during movement.
But because tendons bear the direct concentrated force of our muscular output, they are the most frequent casualty in musculoskeletal disorders.
Yeah, and what's fascinating here is one of those critical distinctions in the entire textbook,
Hmm.
a distinction that fundamentally invalidates the way millions of people treat their chronic injuries.
You were talking about the clinical difference between tendinitis and tendinosis. This section of the text is a complete paradigm shift for anyone who has ever iced a sore elbow or a nagging knee.
Right. The suffix itis in medical terminology explicitly denotes an inflammatory process.
Yeah.
Therefore, tendinitis is by definition an active inflammatory response to microstructural damage within the tendon.
So you have bleeding, swelling, immune cell infiltration, and heat?
Which sounds terrible, but the text makes it very clear that inflammation is the required first step of the body's natural healing cascade. We'll get into the exact cellular mechanics of that later.
But the bombshell in the text is that true chronic tendinitis is exceedingly rare.
Yes, the vast majority of chronic tendon pathologies, the cases of tennis elbow or jumper's knee or Achilles pain that linger for 6 months or a year, are not inflammatory. They are degenerative.
The correct clinical term is tendinosis with an OSIS.
Exactly. Tendinosis describes a tissue that has fundamentally failed to heal. It is not inflamed, it is rotting from the inside out, structurally speaking.
Wow, rotting from the inside out. The histopathology of tendinosis is fascinating and deeply problematic.
It really is. When a physician looks at tendinosis tissue under a microscope, they do not see the classic inflammatory cells like macrophages or neutrophils.
Right, instead they see mucoid degeneration. The perfectly aligned suspension bridge collagen fibers we just described lose their parallel organization. They separate and fray and become a chaotic, structurally weak tangle.
Yeah, and the text also mentions changes to the vascular system within the tendon. The body attempts to heal the degeneration by desperately growing new blood vessels into the tissue, a process called neovascularization.
But these new vessels are poorly formed and are accompanied by new nerve endings, which just flood the brain with chronic pain signals.
The clinical revelation here cannot be overstated. If we connect this histopathology to common real-world treatment methods, we uncover a massive disconnect. Consider a runner who has experienced Achilles pain for 8 months. What is their immediate instinctual response before and after a run?
Oh, they grab a bag of frozen peas to ice the tendon and they swallow a handful of ibuprofen. They aggressively treat the injury with anti-inflammatory modalities.
Right, and they are actively treating a biological condition they do not have, because tendinosis does not involve inflammation. So anti-inflammatory drugs will do absolutely nothing to repair the frayed collagen or halt the mucoid degeneration.
In fact, the textbook argues that constantly suppressing the local metabolic rate with ice and blunting the cellular signaling with NSAIDs might actually be stalling the very cellular processes required to initiate tissue remodeling.
Exactly. You are essentially throwing a bucket of ice water on a frayed suspension bridge cable and wondering why the steel isn't mending itself.
You are targeting a symptom that isn't there while the underlying structural decay continues unabated. It forces clinicians and patients to entirely abandon the rest and ice protocol for chronic tendon issues.
Because degenerative tissue requires highly specific, mechanically controlled loading to stimulate the fibroblasts to lay down new healthy collagen.
We will definitely explore those specific loading protocols in the rehabilitation section. But before we leave the microscopic blueprint of the body, we have to look at the third connective tissue highlighted in the text, cartilage.
Yes, specifically, the authors focus on fibrocartilage and hyaline cartilage. Fibrocartilage is the heavy-duty, dense shock absorber of the skeletal system.
So the menisci in the knees, the labrum in the shoulder socket, and the intervertebral discs of the spine are all composed of fibrocartilage.
Right. It is incredibly resilient tissue designed to withstand massive compressive forces. But hyaline cartilage is where the textbook reveals a massive biological vulnerability.
Hyaline cartilage is the slick, pearlescent tissue that coats the articular ends of our bones where they meet inside a joint capsule.
Yes, it is designed to create an almost frictionless surface for the bones to glide against. But the vulnerability lies in its vascularity, or rather the complete lack of it. Hyaline cartilage is avascular.
Meaning it possesses almost no direct blood supply. In human biology, the circulatory system is the supply chain right. Blood carries the oxygen, the amino acids, and the glucose that cells require to survive, function, and repair damage.
Exactly.
So if a tissue has no blood vessels, how do the chondrocytes, the cells that maintain the cartilage, actually stay alive?
The text describes a brilliant, purely mechanical survival mechanism. Hyaline cartilage maintains its nutrient supply through a process of diffusion driven entirely by physical loading and unloading.
Right. The text says cartilage is highly biphasic, meaning it consists of a solid matrix of collagen and proteoglycans heavily saturated with a fluid phase.
The analogy that always comes to mind here is a dense kitchen sponge submerged in water.
That is a highly accurate comparison. When mechanical weight is applied to the joint, like when you take a step or land from a jump or hold a heavy barbell, the sheer compressive force squeezes the cartilage.
And this physically forces the fluid along with accumulated metabolic waste products out of the cartilage matrix and into the surrounding synovial space.
And the crucial second half of the mechanism occurs when you take the weight off. When the joint is unloaded, the pressure drops and the cartilage rapidly expands back to its normal shape.
Right, and as it expands, it acts like a vacuum sucking fresh, nutrient-rich synovial fluid back deep into its core. Squeeze the dirty water out, soak the clean water up.
This cyclical mechanical pumping action is the absolute only way hyaline cartilage receives nutrition, which exposes a terrifying reality for anyone living a highly sedentary lifestyle.
Oh, absolutely. If you do not mechanically load and unload your joints through regular movement, that sponge never gets squeezed. The diffusion process halts.
The cartilage is literally starving to death in a static environment. The tissue begins to thin, become brittle, and lose its frictionless properties.
It is the ultimate biological proof that the human body requires physical stress to survive. Movement is quite literally the food source for your joints.
But as the entire premise of the textbook suggests, this biological requirement for stress is a double-edged sword. Movement feeds the tissue, but excessive movement destroys it.
Exactly. We've mapped out the materials, the ligaments, the tendons, the cartilage. Now we need to dive into the physics of how those materials are pushed past their limits.
We need to look at the specific physical actions that cause catastrophic breakdown. And the text is unambiguous in identifying the primary culprit for extreme mechanical strain on soft tissue. It isolates a specific type of muscular action, the eccentric contraction.
Yeah, this is a concept that usually flips people's understanding of exercise upside down. When we think of a muscle working, we visualize it shortening.
Like you curl a dumbbell upward toward your shoulder, your bicep bulges and shortens. That is a concentric contraction.
Right, but an eccentric contraction is the exact opposite. It occurs when a muscle is producing force while simultaneously lengthening under tension.
The muscle is acting as a biological brake against an external force, usually gravity or momentum.
Yes, if curling the dumbbell up is concentric, slowly lowering that heavy dumbbell back down to your waist is eccentric. Your bicep is lengthening, but it is fighting desperately to control the speed of the descent so your arm doesn't just drop instantly.
The textbook uses running downhill as the classic high-impact example, right? Every time your foot strikes the decline, the quadriceps in the front of your thigh must eccentrically contract to absorb the impact and prevent your knee from simply buckling under your body weight.
The downward phase of a heavy squat or the act of landing from a jump are all dominant eccentric actions too. And the text makes a striking biomechanical point here. It states that eccentric contractions generate significantly higher amounts of muscular force than concentric contractions.
Which comes down to the microscopic physiology of the muscle fibers. During a concentric contraction, the actin and myosin filaments inside the muscle are sliding past each other, forming cross bridges to pull the muscle shorter. It's a highly coordinated pulling action.
But during an eccentric contraction, those cross bridges are still trying to pull, but the external weight is so heavy that the fibers are physically being ripped apart and lengthened anyway.
But the myosin heads are essentially trying to row backward against a tidal wave.
That is exactly it. Because the load is so extreme, the nervous system recruits fewer motor units to handle the eccentric load, meaning the mechanical stress per muscle fiber is astronomically higher.
In the text notes, this extreme strain is primarily localized in the fast glycolytic muscle fibers, the type D fibers responsible for explosive power.
This specific brutal strain on the cellular architecture is why eccentric loading is the primary cause of DOMS, delayed onset muscle soreness.
DOMS is the agonizing stiff pain that sets in 24 to 48 hours after unaccustomed exercise, right?
Yeah, like if you haven't run in 6 months and you decide to jog 3 miles on a route with steep downhills, the excessive eccentric braking action literally causes microscopic tearing of the muscle fibers and the connective tissue encasing them.
The soreness is the resulting inflammatory cascade attempting to clean up the microscopic wreckage. And the text doesn't just blame gravity, it introduces the physics concept of momentum to explain how we accidentally amplify these eccentric forces to dangerous levels.
Momentum is mass multiplied by velocity. To illustrate how small changes in momentum create massive joint-destroying torque, the authors detail a specific gym exercise, the triceps kickback.
Right. The exercise involves leaning forward, supporting yourself on a bench, and extending your arms straight back behind you while holding a dumbbell, isolating the triceps muscle.
And the text breaks the movement down into 3 variations, labeled levels A, B, and C, to demonstrate the escalating danger of uncontrolled momentum. Level A represents flawless execution.
The client uses a lightweight, keeps their upper arm pinned motionless against their ribs, and solely pivots at the elbow joint.
Exactly. The mass is low, the velocity is controlled, and the lever arm is short. The momentum is negligible. But level B introduces biomechanical cheating.
Oh, the classic gym cheating.
Right. The client grabs a weight that is too heavy for their triceps to move in isolation. To compensate, they unpin their upper arm and begin swinging the entire arm from the shoulder joint to get the weight moving.
And by swinging from the shoulder, they have drastically lengthened the lever. The mass is now further away from the axis of rotation, which instantly increases the torque demands on the surrounding connective tissue.
But level C is where injury becomes highly probable. The client is now using an excessively heavy weight, and to move it, they are violently rotating their entire spine and throwing the dumbbell backward with maximum speed.
They've maximized both mass and velocity, creating a massive surge in momentum. But here's the critical failure point the text highlights. What goes up must come down, or in this case, what accelerates must be decelerated.
Yes. When that heavy, rapidly moving dumbbell hits the absolute end of the arm's range of motion, the elbow joint physically cannot extend any further. All that accumulated momentum must be absorbed instantaneously.
The joint capsule, the ligaments, and the triceps tendon must eccentrically act as a crash barrier to stop the weight.
And the sudden violent torque strain placed on the elbow and the lower back in level C is catastrophic. It is the perfect recipe for a sudden rupture.
But what actually happens inside the tendon or the ligament at the exact millisecond it absorbs that shock? Like, how much force does it take to permanently alter human tissue?
To answer that, the textbook transitions from kinesiology into pure materials engineering. It introduces the defining biomechanical graph of soft tissue injury, the stress-strain curve.
This concept is incredibly powerful because it gives a visual mathematical reality to the injuries we've all experienced. The stress-strain curve tracks the physical deformation of a tissue as increasing loads of force are applied to it.
Right, the journey begins on the left side of the graph in the elastic range.
And the elastic range represents normal, healthy movement, right?
Yes. When a relatively small load is applied to a tendon or ligament, the wavy, crimped collagen fibers simply straighten out to accommodate the tension. It functions exactly like a high-quality spring.
The defining characteristic of the elastic range is that once the force is removed, like when you drop the weight or finish the movement, the tissue snaps perfectly back to its original resting length and shape. There is zero permanent structural change.
However, as the force continues to increase, the tissue reaches a critical biomechanical threshold known as the yield point.
And the numbers the textbook provides here are sobering. For a dense ligament, the yield point can be reached with just a 4% change in length.
4% elongation. It is an incredibly narrow margin of safety.
If you push the tissue even a fraction of a millimeter past that 4% yield point, you leave the safety of the elastic range and cross into the plastic range.
And the plastic range is the biological danger zone. Once tissue enters the plastic range, permanent microscopic deformation occurs.
The text explicitly describes the mechanism as the slippage of collagen crosslinks. The chemical bonds holding the fibril bundles together begin to shear and fail.
The tissue is elongating, but it is losing its structural density to do so. The spring is being overstretched. Energy from the excessive force is being dissipated by actively destroying the microscopic architecture of the tissue.
It cannot and will not return to its original shape when the load is removed. It is permanently altered.
Right. And if the force continues to climb within the plastic range, you inevitably arrive at the terminal end of the graph, the rupture point. This is the moment of macro failure. The tissue completely severs.
The textbook puts this physics lesson into immediate, terrifying context for athletes. It notes that the mechanical demands of many explosive sports, like soccer, basketball, rugby, or sprinting, regularly require repetitive tendon loading that results in an 8% change in length.
Which means the athletes are not operating in the elastic range. Every time they plant their foot to change direction or explode upward for a rebound, their tendons are stretching well past the yield point and operating deep within the plastic range.
Here is where it gets really interesting, though. I kept visualizing a cheap plastic grocery bag while reading this section. It's the most perfect real-world representation of the stress strain curve.
Oh yeah, that's a great analogy.
Right, like if you put a small box of cereal in the plastic bag and lightly bounce it, the plastic stretches a tiny fraction and immediately snaps back. That's the elastic range.
The structural integrity of the bag is fully maintained.
But if you take that exact same bag, load it with 3 heavy gallons of milk, and lift it aggressively off the ground, the physics change. You see the plastic handle rapidly stretch. The material turns an opaque, cloudy white. It gets incredibly thin and physically distorted.
Yeah, the handles are now twice as long as they used to be. You have forced the bag past its yield point and into the plastic range. The polymer chains of the plastic have slipped exactly like the collagen crosslinks.
The bag hasn't broken yet, but it is permanently ruined. It will never shrink back to its original shape. And if you bounce that bag one more time, the thin plastic hits the rupture point, completely tears in half, and the milk shatters on the pavement.
But you know, the clinical reality, however, is that you rarely need 3 gallons of milk to cause a rupture. And this transitions us into the most insidious concept in the textbook.
We are shifting from acute sudden traumas like an ACL snapping under a massive tackle to the slow, silent accumulation of damage.
Right, the text calls it the overuse spiral. Because what if you aren't loading the grocery bag with 3 gallons of milk? What if you only load it with a weight heavy enough to stretch it by a microscopic fraction of a millimeter?
The bag survives today. But what if you do it again tomorrow? And the next day?
This is where the initial equation, intrinsic plus extrinsic risk, really manifests over a timeline. The textbook maps out a highly predictable cyclical pathway to chronic injury. The spiral initiates with what clinicians call subclinical tissue overload.
Subclinical is the crucial word there. It means the damage is occurring below your sensory threshold. You don't feel it.
Exactly. Say you went for a 5-mile run, your biomechanics were slightly asymmetrical due to a weak hip, and you forced your patellar tendon to absorb a tiny bit too much eccentric force. You caused microscopic fraying in a few collagen fibers.
But you have no pain. You think it was a great workout.
Microtrauma has occurred. Now we must look at the biological recovery timeline. In a healthy periodized training program, what is supposed to happen after microtrauma is induced?
You rest. You take a recovery day. The body detects the microtrauma, initiates a mild localized healing response, clears out the damaged fibers, and synthesizes new, slightly stronger collagen in its place.
That is the fundamental principle of physical adaptation. You bring it down slightly to build it back stronger, but the overuse spiral is defined by a critical absence, inadequate rest or repair.
The client feels fine, so they run again the very next day.
Right, the tendon hasn't had the time to fully reconstruct those frayed fibers.
Exactly. So the tissue experiences a second wave of microtrauma while it is still structurally compromised from the first. This compounds the damage, leading to a state of tissue fatigue.
The tensile strength of the tendon is now objectively lower than it was before the training block started.
And because the baseline strength is lower, the exact same 5-mile run on day 3 causes exponentially more microscopic tearing. It is a compounding debt of cellular damage.
And you know, the most alarming detail in this entire section of the text is the timing of when symptoms finally appear. The authors state definitively that clinical symptoms like pain, stiffness, or swelling only emerge after the tissue has fundamentally lost its biological capacity to repair itself between training sessions.
Oh, wow. By the time the central nervous system registers pain, The structural degradation is already highly advanced. You are not feeling the initial injury, you are feeling the tissue actively failing to cope with the accumulated debt.
Right. To help clinicians and clients navigate this murky timeline, the textbook relies on a diagnostic tool developed in 1988 called the Inertial Pain Scale for overuse injuries.
It breaks the progression of pain into 7 distinct phases, right? Understanding the scale is probably the most valuable diagnostic skill you can take away from this material.
Absolutely. Phases 1 and 2 are where the psychological trap is set. Phase 1 is defined as stiffness or mild soreness that appears after an activity but completely resolves within 24 hours.
This is often indistinguishable from standard muscular fatigue.
But phase 2 is the pivotal warning sign. Phase 2 involves stiffness or localized aching that is present before the activity begins. You wake up with it.
However, once you start moving and blood flow increases, the pain entirely vanishes during the workout.
This creates a deeply deceptive biofeedback loop. The client wakes up, their Achilles tendon is stiff, and they hobble out of bed. But they force themselves to go to the gym, they jump on the treadmill, and after a 5-minute warm-up, they feel absolutely fantastic.
I have fallen for this trap dozens of times myself. You think I am not injured. My body just needed to loosen up. The movement cured the stiffness.
You view the disappearance of the pain as validation to push harder. But the textbook is vehemently warning us that phase 2 pain is not just a need to loosen up.
The pain disappears because the movement temporarily increases the local temperature and synovial fluid viscosity, masking the symptoms.
Right, but the structural decay is still present, and you are actively worsening it by training on it. Phase 2 is the fire alarm of the overuse spiral.
Okay, I have to push back here on behalf of the listener just regarding the practical reality of this clinical advice. I understand the biology, but let's say you are a trainer working with a client who is 6 weeks out from running a marathon.
Right.
If they wake up with a stiff Achilles that completely vanishes during their warm-up, and you tell them, well, the text says you have phase 2 overuse, you need to halt your marathon training immediately for weeks, they're going to laugh in your face and fire you.
That is very true.
How does a normal person differentiate between the standard "I trained hard yesterday" muscle soreness and the catastrophic "my tendon is failing" phase 2 stiffness?
That is the exact friction point between clinical idealism and athletic reality. The differentiation comes down to location persistence and the nature of the pain. Standard DOMS, the acceptable muscle soreness, peaks at 48 hours and dissipates. Furthermore, it is located in the belly of the muscle.
Okay, so the muscle belly versus the joint.
Yes. The pain described in phase 2 of the inertial scale is persistent. It happens every single morning, unbroken for weeks. More importantly, it is highly localized to the connective tissue. The insertion points at the joints, the patellar tendon, the lateral epicondyle of the elbow.
If your actual joint architecture is stiff every morning for 3 weeks, regardless of whether it warms up, that is accumulated microtrauma, it is not standard adaptation.
Oh, I see.
That distinction between the muscle belly and the joint insertion point is incredibly helpful because if you choose to ignore that persistent phase 2 warning and push through, the scale accelerates rapidly. Phase 3 introduces pain that is present before, during, and after the activity, though you can still technically perform.
By phase 4, the biological damage crosses a threshold where the pain actually alters your biomechanics. You start subconsciously limping during the run. You change your throwing motion to protect the shoulder.
Which ironically just creates massive new intrinsic risks because you are now moving asymmetrically, destroying other joints in the process.
Exactly. And the scale bottoms out at phases 6 and 7. Phase 6 is intermittent pain even while completely resting. Phase 7 is constant aching pain that disrupts sleep on a nightly basis. The tissue is in a state of advanced, potentially irreversible structural failure.
The textbook spends time diagnosing why clients so frequently ride the scale all the way to the bottom. It highlights a massive cultural and psychological hurdle, the ingrained no pain, no gain mentality.
Right. People actively mask their pain, sometimes taking NSIs before they even go to the gym, because they have internalized the idea that pushing through discomfort is a metric of mental toughness and dedication.
It is a catastrophic misunderstanding of physiology. They believe they are forging resilience, but biologically they are just continually forcing their tissue deeper into the plastic range.
They take what was originally a minor, easily reversible microtrauma in phase 1, and through sheer stubbornness, transform it into a chronic degenerative tendinosis that might require a year of complex rehabilitation.
Aside from the subjective feeling of pain, the text lists objective physical warning signs that trainers and individuals must monitor. Localized warmth over a tendon-visible swelling. And one diagnostic sign that genuinely makes my skin crawl: crepitus?
Ah, yes, crepitus.
Ah.
It is the physical auditory manifestation of advanced structural decay within the joint capsule or the tendon sheath.
The textbook provides a very specific auditory comparison. It is the crackling, grinding sound, similar to what you hear when you take a pinch of your own hair and tightly roll it between your fingers right next to your ear.
Just the thought of a tendon sounding like crunching hair is horrifying.
It really is. But mechanically, what is actually causing that sound?
It indicates that the frictionless environment has been entirely compromised. The smooth, pearlescent hyaline cartilage we discussed earlier has worn away, leaving roughened, damaged surfaces grinding against each other.
Or, in the case of a tendon, the specialized epitendinium sheath is inflamed and swollen, causing the tendon to violently catch and scrape against the surrounding tissues rather than gliding smoothly.
Right, it's the sound of the biological machinery operating without any oil.
So let's look at the worst case scenario. We ignored the intrinsic risks, we committed the extrinsic training errors, we ignored the morning stiffness of phase 2, and we pushed our tissue so far into the plastic range that the collagen crosslinks finally gave way. We have a rupture or severe debilitating damage.
Okay, so what happens the millisecond after the tissue tears? How does a biological organism actually patch a physical hole in its own architecture?
This brings us to the most clinically vital section of the textbook, the 3 phases of healing.
Yes, if there is one section of this text that should dictate human behavior regarding injury, it is this one. The body executes a rigid, non-negotiable sequence of cellular events to repair damage. You cannot skip a phase, and if you interrupt a phase, you halt the entire process.
The sequence begins immediately with phase 1 inflammation. The text provides a standard timeline of 0 to 5 days post-injury. And the primary biological objective here isn't to fix the tissue, it is stabilization. It is pure damage control.
The instant the tissue ruptures, thousands of cells are destroyed and local blood vessels are severed. Bleeding occurs internally. The very first response is hemostasis.
Platelets in the blood rush to the site, adhere to the damaged tissue, and initiate a massive clotting cascade. They rapidly spin a dense meshwork of a protein called fibrin to plug the severed vessels and physically contain the injured area.
Once the bleeding is contained, the chemical signaling begins. The damaged cells release a flood of biochemical mediators, most notably histamine. The histamine triggers severe vasodilation.
The intact blood vessels surrounding the injury rapidly widen and become highly permeable.
This vasodilation is what causes the cardinal signs of inflammation. The intense redness, the localized heat, and the rapid painful swelling as plasma and immune cells flood into the interstitial space.
It creates immense pressure, which causes the acute pain associated with a new injury. But that swelling isn't a mistake, it's a delivery system.
Exactly. The vasodilation is creating a biological superhighway for the cleanup crew. The text specifically highlights the arrival of neutrophils and macrophages.
Macrophages are essentially the heavy machinery of the immune system. They are specialized phagocytic cells.
Their singular job is to arrive at the injury site and literally consume and digest the microscopic wreckage, the dead cells, the torn collagen fibers, the coagulated blood. They are aggressively clearing the site so that actual rebuilding can occur.
The analogy that perfectly captures phase 1 is a catastrophic accident on a major highway. The moment the crash happens, emergency first responders rush in and completely lock down the site.
Right, the police throw up barricades and close the lanes. That is the swelling and the fibrin clotting isolating the damage.
The firefighters suppress the immediate danger, and then the massive tow trucks, the macrophages, arrive to physically haul away the twisted metal of the wrecked cars.
It is a chaotic, swollen, incredibly painful scene, but it is an absolutely mandatory prerequisite for repaving the road.
Which brings us back to the most controversial debate in sports medicine. A debate the textbook addresses with extreme caution. If this chaotic inflammation phase is biologically required to clear the wreckage, why is the universal human instinct to immediately suppress it with medication?
We are back to the NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, Advil. When you swallow an NSAID after an acute injury, what is happening on a chemical level?
NSAIDs operate by inhibiting specific enzymes in the body, primarily COX-1 and COX-2, which are responsible for synthesizing chemical compounds called prostaglandins.
Prostaglandins are the primary drivers of the inflammatory cascade. They cause the vasodilation, they increase the swelling, and they sensitize the nerve endings to generate pain signals.
So the ibuprofen blocks the prostaglandins, the swelling goes down, and the pain vanishes. To the patient, they feel healed.
But the textbook explicitly warns that the use of NSAIDs may blunt the normal healing process. Prostaglandins don't just cause pain, they are the chemical messengers that recruit the macrophages to clean the site, and they eventually signal the fibroblasts to begin rebuilding.
If you take high doses of NSAIDs, you are essentially firing the site foreman at the crash site. The tow trucks never get the call to come haul away the wrecked cars. The debris remains trapped in the tissue.
The pain is masked, which often gives the client a false sense of security, leading them to prematurely load the injured tissue. The text warns that masking pain and pushing through an unhealed injury exponentially increases the risk of worsening the structural damage.
You are turning off the fire alarm while the kitchen is still actively burning.
That is a really good way to put it, actually. Now, the textbook does present a slightly different biological mechanism regarding the use of ice or cryotherapy.
Ice is almost universally applied to acute injuries, but the text clarifies that ice doesn't chemically block the prostaglandin cascade the way NSAIDs do. Instead, it alters the hemodynamics.
Ice induces powerful vasoconstriction. The blood vessels rapidly narrow, which severely restricts localized circulation. This drastically lowers the metabolic rate of the tissues, slowing down the inflammatory processes and providing intense immediate pain relief by numbing the nerve ending.
However, the text is very specific in its recommendation for how to use ice. It advises brief, intermittent applications, 5 to 10 minutes maximum, followed by removal. It specifically argues against leaving a joint packed in ice for hours. Why is the brief application so critical?
It utilizes a physiological phenomenon called the rebound effect. When you apply the ice, the vessels clamp down tightly. But the moment you remove the ice, the body aggressively overcompensates.
The vessels rapidly dilate, causing a massive, forceful influx of arterial blood and lymphatic activity to rush back into the area.
It creates a biological flush.
Yes. That sudden pressurized surge helps mechanically evacuate the cellular debris that the macrophages are trying to clear.
Therefore, brief intermittent icing manages the agonizing pain and prevents the swelling from becoming dangerously excessive without permanently halting the metabolic repair timeline.
So assuming we don't chemically sabotage the first responders, the macrophages eventually finish hauling away the wreckage. The site is clear. Usually around day 3 to 5, the biological machinery shifts into phase 2 proliferation or the repair phase.
The textbook gives a timeline here of roughly 3 to 21 days post-injury. This is the active rebuilding phase. The cellular profile of the area completely changes. The macrophages begin to migrate out of the tissue, and a vital process called angiogenesis initiates.
Angiogenesis. The spontaneous generation of completely new blood vessels. The body literally builds a temporary plumbing system to pump massive amounts of oxygen and nutrients directly into the construction site.
And the primary laborers that rely on that new blood supply are the fibroblasts. The text details how fibroblasts migrate into the cleared area and immediately begin synthesizing and secreting massive amounts of cellular building blocks.
The two primary materials they lay down are ground substance and collagen. Ground substance is a highly viscous, gel-like fluid rich in glycosaminoglycans. It acts as the biological mortar.
And into that mortar, the fibroblasts start rapidly spinning webs of type 3 collagen and elastin.
But the textbook emphasizes a critical structural flaw in this phase. The type 3 collagen being laid down is weak, immature, and fundamentally disorganized.
The body is acting with immense urgency. Its sole priority is to close the gap and reconnect the severed tissues as fast as possible. It values speed over structural perfection.
Returning to the construction analogy, phase 2 is like the contractors arriving and just wildly pouring fresh, wet, highly chaotic concrete everywhere.
The resulting scar tissue is bulky red and physically much larger than the surrounding healthy tissue because it is heavily saturated with fluid and edema. It bridges the gap, but it has no real tensile strength.
This phase represents the most vulnerable period in the entire recovery timeline for an athlete. Because the initial agonizing inflammation has subsided, the client often feels significantly better. The sharp pain is gone. They believe they are healed.
But if they take that chaotic, wet concrete web of type 3 collagen and subject it to a heavy eccentric contraction if they try to sprint or lift heavy, that weak scar tissue will immediately shear and tear apart.
And they're instantly teleported back to day 0 of phase 1. The bleeding starts again, the swelling returns, and the timeline resets.
Patience during the proliferation phase is biologically non-negotiable. You have to wait for the concrete to dry and cure.
Which brings us to the final and most prolonged stage of the textbook's biological timeline. Phase 3 remodeling. This phase begins around day 7 and shockingly can continue for well over a year.
The remodeling phase is where the disorganized, bulky scar tissue is refined and strengthened into functional tissue. The cellular actors change again. The specialized fibroblasts transform into myofibroblasts.
These cells have contractile properties similar to muscle cells, and they physically latch onto the edges of the wound and contract, pulling the tissue tighter and physically shrinking the scar.
But the true magic of the remodeling phase lies in what happens to the collagen. The weak type 3 collagen is gradually absorbed and replaced with much stronger, mature type I collagen. However, just dumping stronger collagen into the site isn't enough. It has to be organized.
The text highlights a principle that dictates this entire process. Form follows function.
The new collagen fibers are initially disorganized. But as mechanical stress is applied to the tissue, the fibers physically read those lines of tension. They begin to produce chemical crosslinks and actively align themselves perfectly parallel to the direction of the stress.
The sculptors have arrived to carve the bulky concrete to perfectly match the sleek architecture around it. They are maximizing the tensile strength of the tissue to handle specific loads.
But the biological catch is profound. The cellular sculptors are blind. They only know what shape to carve the tissue into based entirely on the mechanical stress signals you provide them.
If you do not apply the correct progressive lines of tension to the healing tissue, the collagen remains a chaotic, weak, disorganized mess permanently.
Which is the perfect transition into the final major section of our deep dive today. Section 5, the road back, rehabilitation.
We now fully understand how the cells attempt to heal the injury. But how do we physically train a healing body? How do we provide the necessary mechanical stress to align the collagen without accidentally applying too much force and ripping the wet concrete?
The textbook transitions from pathology to practical prescription, outlining a highly structured three-stage progression for rehabilitating injured clients. The protocol requires the clinician to perfectly synchronize their exercise prescription with the biological phases of healing we just discussed.
Stage 1 is labeled the acute response stage. Predictably, this aligns perfectly with the biological phase 1, the inflammation phase.
The primary objective here is not to gain strength or improve fitness. It is simply to control the biological chaos and manage the swelling. The text recommends the universally recognized PRICE method: protection, rest, ice compression, and elevation.
We've discussed the nuances of brief icing, but the textbook emphasizes the mechanical importance of elevation. You want the injured limb elevated above the level of the heart.
This allows gravity to assist the lymphatic system in physically draining the excessive edema away from the extremity and back into central circulation.
Of course, protection and rest are paramount to prevent further severing of the tissue. However, the text inserts a massive caveat regarding rest.
As we explored during our discussion on avascular hyaline cartilage, absolute prolonged immobilization is catastrophic. If you completely cast a joint for weeks, the cartilage starves, the tendons weaken, and the muscles rapidly atrophy. Rest means protecting the injured area from extreme loads, not absolute paralysis.
Which is why the moment the acute painful inflammation begins to subside, the protocol dictates moving into stage 2 recovery. This stage clinically aligns with the biological proliferation phase where the chaotic type 3 collagen is being poured.
The goal of stage 2 is a delicate balancing act. You must introduce enough mechanical stress to prevent rapid muscular atrophy and maintain some joint lubrication. But the stress must be low enough that it doesn't shear the fragile new scar tissue.
The textbook prescribes 2 highly specific modalities for this stage. First, isometric exercises.
An isometric contraction is when the muscle fires and generates tension, but the joint angle does not change and the muscle does not lengthen or shorten. Pushing your hands forcefully against a solid brick wall is an isometric contraction.
Isometrics are invaluable in phase 2 because they allow the nervous system to recruit motor units and maintain muscle density without exposing the healing tendon to the dangerous shearing forces of movement or the catastrophic torque of eccentric braking.
The second modality the text suggests for stage 2 is mid-range isotonics with negligible weight. You move the joint, but only through a strictly limited, entirely pain-free range of motion.
The textbook offers a brilliant real-world example of stage 2 cardio for an injured runner. Deep water running with a flotation belt.
It is an elegantly designed prescription. The client is submerged in water wearing a belt that keeps them entirely afloat. They mimic the exact biomechanical running motion against the resistance of the water.
It accomplishes everything necessary while avoiding all the risks. The cardiovascular system works hard. The neurological firing patterns of the running stride are maintained.
But because the client never actually strikes the ground, the buoyancy entirely eliminates the extrinsic forces of gravity and impact. There is zero heavy eccentric loading. The fragile wet concrete of the tendon is perfectly protected while the surrounding muscles get to work.
It is the pinnacle of stage 2 management. But eventually, the biological timeline shifts into phase 3 remodeling. The concrete is dry and it needs to be sculpted. The clinical protocol moves to stage 3 functional progression.
This is where we have to actively teach the new collagen fibers how to align themselves, and more importantly, we have to reboot the neurological alarm systems that were damaged.
The textbook places immense weight on introducing proprioceptive challenges during stage 3. Remember the microscopic mechanoreceptors in the ligaments that were severed during the sprain?
The brain's kinesthetic map of the joint is corrupted. You cannot fix that with a leg press machine.
The text lists specific balance and stability drills to force the nervous system to recalibrate. Exercises like stork stands simply balancing on one leg for extended periods, or utilizing unstable surfaces like a wattle board or a BOSU ball.
By placing the joint in a controlled, unstable environment, you are forcing the surviving and newly formed proprioceptors to rapidly fire, sending high-speed data back to the central nervous system to make micro-adjustments. You are actively rewiring the neurological communication lines.
And as the tissue organizes and the proprioception returns, the text dictates that the trainer must progressively reintroduce the most dangerous force of all, eccentric loading.
You eventually have to prescribe plyometrics, jumping, bounding, and rapid deceleration. You have to safely expose the remodeled tissue to the exact violent forces it will inevitably encounter in the real world to ensure the collagen has aligned perfectly to handle them.
To synthesize all of these complex biomechanical and biological principles, the textbook concludes this section with a highly relatable real-world case study. A 35-year-old woman who presents to a trainer with severe debilitating pain in both her Achilles tendons and her patellar tendons.
Let's dissect her training history, because it serves as the ultimate diagnostic test for everything we've covered today. Her baseline history. For 5 weeks, she had been jogging for 20 to 25 minutes a day, 2 or 3 days a week. She was entirely asymptomatic, no pain, no stiffness. She felt fantastic.
But then there is a sudden extreme deviation in her behavior. Without any preparatory training, she decided to participate in an intense 2-hour competitive volleyball tryout. 3 days later, her tendons are essentially screaming and she can barely walk down a flight of stairs.
If we run her scenario through the foundational equation, intrinsic risk plus extrinsic risk equals injury, what does the textbook reveal?
The extrinsic training error is glaringly obvious. It is a textbook example of abusive tissue overload. We have to analyze the biomechanical differences in her activity. For 5 weeks, her tissue had perfectly adapted to the specific mechanical stress of light jogging.
And light jogging is a highly predictable, low-impact, strictly linear motion. The joints are moving straight ahead within a very narrow range of motion for only 20 minutes.
Exactly. Then, in a single day, she subjects those linearly adapted tissues to 2 hours of volleyball. Volleyball is a fundamentally different biomechanical universe. It is highly multidirectional, requiring violent lateral cutting. It is explosive. But most importantly, it is deeply reliant on heavy eccentric loading.
Jumping maximally into the air to spike a ball and then landing on a hard gymnasium floor. Over and over again for 2 hours.
Her fast glycolytic muscle fibers and the collagen crosslinks in her patellar and Achilles tendons were subjected to astronomical levels of unaccustomed momentum and eccentric torque.
Her tissues were completely unprepared for that specific vector of stress. The force rapidly pushed her tendons past the 4% yield point deep into the plastic range, causing massive widespread microtrauma.
Now, a standard trainer might look at her, diagnose the acute inflammation, and prescribe a logical stage 1 and stage 2 response. Ice and rest to manage the swelling, followed by a transition into an aquafit program to maintain her cardiovascular fitness without further eccentric loading.
But the textbook issues a massive critical warning regarding that exact approach. It says that the aquafit program will eventually allow her biological healing phases to complete. Her pain will go away. She will be able to return to her 20-minute linear jogs without issue. But the text argues the treatment plan is a catastrophic failure because it completely ignores the I in the equation.
It entirely ignores the intrinsic risk. The critical diagnostic question the clinician must ask is, why did her specific tendons fail so spectacularly when there were likely dozens of other 35-year-old women at that exact same volleyball tryout who woke up the next day feeling perfectly fine?
The extrinsic error of the 2 hours of jumping was the catalyst, but it was just the potholes on the road. What was wrong with her car?
The textbook mandates that once her acute discomfort subsides, the trainer must launch a rigorous investigation into her specific biomechanical architecture. They must evaluate her muscle balance, her pelvic alignment, her joint stability.
Does she have weak glute medius muscles that cause her knees to violently collapse inward into a valgus position every time she lands from a jump? Does she severely overpronate at the ankle, transferring rotational torque directly into the Achilles? Does she have severely tightened hip flexors that alter her landing mechanics?
If the clinician merely waits for the biological phases of healing to run their course, but fails to uncover and actively correct those underlying intrinsic structural flaws, the prognosis is guaranteed. The very second she steps back onto a volleyball court and exposes herself to those multidirectional eccentric forces, the asymmetrical loading will immediately show the new collagen and the injury will return instantly.
You cannot just patch the tire. You have to fix the alignment or the tire will blow out on the exact same pothole. Rehabilitation, as defined by this clinical text, isn't just a waiting game for the pain to stop.
It is an active, investigative biomechanical remodeling process designed to fundamentally alter the equation that caused the injury in the first place. It is such an empowering perspective. You aren't just a passive victim of a torn tendon. You have the biological agency to rebuild the architecture stronger and more resilient than it was before the failure.
Wow. We have navigated an immense amount of clinical and physiological ground today. We started by defining the fundamental equation of soft tissue failure, intrinsic anatomical risk colliding with extrinsic training errors.
We zoomed in to examine the incredible, highly organized architectural hierarchy of our ligaments and tendons. We exposed the critical difference between the active inflammation of tendinitis and the cellular decay of tendinosis, highlighting why anti-inflammatory drugs are often the absolute wrong tool for chronic joint pain.
We mapped out the unforgiving physics of the stress-strain curve, demonstrating how the dangerous torque of eccentric momentum can permanently stretch our collagen into the plastic range, just like a cheap grocery bag carrying too much weight.
We explored the deceptive silent trap of the overuse spiral, where our clients tragically mistake the structural alarm bell of phase 2 morning stiffness for a simple need to warm up, actively driving their tissue toward rupture.
And we marveled at the incredibly coordinated microscopic miracles of the three healing phases, from the first responder macrophages clearing the cellular wreckage in the inflammation phase, to the chaotic, messy concrete pour during the proliferation phase, to the precise, tension-guided sculpting of type I collagen during the remodeling phase.
And finally, we saw the absolute necessity of a progressive, biologically synchronized rehabilitation plan that actively retrains the nervous system.
The overarching mandate from the clinical text is profound respect for the biological process. You must respect the disproportionate mechanical power of eccentric contractions. You must respect the timeline of the healing cascade. And you must deeply respect the warning signals of the pain scale.
Yes, listen to phase 2 pain. It is not weakness, it is a structural gauge. And definitely take a moment to reconsider reaching for a bottle of ibuprofen the absolute second you feel acute joint pain, because you might just be chemically firing the body's first responders before they even have a chance to clear the wreckage.
That is a crucial takeaway for sure.
But I want to leave you with a final, somewhat provocative thought, extrapolating on the biological laws we just spent the last hour discussing. In the textbook, during the remodeling phase, we learned a fundamental biological truth. Form follows function. The new collagen fibers only know how to align themselves to become strong based entirely on the directional physical stress and tension that is placed upon them.
They require mechanical force to build resilience. We learned that the hyaline cartilage literally requires compressive force just to pump fluid to breathe and eat. Without physical stress, the joint starves.
If our physical tissues literally rebuild their structural architecture and maintain their vitality based entirely on the external stresses we expose them to, what does that biological law mean for the parts of ourselves that we actively try to shelter from all stress? If the absolute total avoidance of physical strain literally starves the cartilage and leaves a tendon as a chaotic, weak, disorganized mess, can the total avoidance of mental, emotional, or psychological strain in our daily lives be just as degenerative as an extreme overload?
That is a fascinating question to end on.
Think about it. In biology, resilience isn't the absence of stress. It is the specific controlled adaptation to it. Are there neural pathways or aspects of your own personal resilience that are currently stuck in a fragile, disorganized state simply because you've decided to stop safely loading them? Are you starving your own capacity by avoiding the very tension required to sculpt it?
It really makes you think about how we treat our minds the same way we treat our bodies.
We started this deep dive by noting that a standard X-ray machine is essentially useless when it comes to diagnosing soft tissue overuse. You can't photograph the microtrauma. But maybe the real diagnostic tool is how we choose to move, how we choose to recover, and how we choose to adapt to the forces acting upon us every single day. Until next time, keep exploring the muddy waters.